Today's discussion will include two amazing panelists. Our first panelist is Dr. David Carlisle, President of Charles Drew University, and Jennifer Waldrop, the Executive Director of the Rare Disease Diversity Coalition. So I'm going to just jump right into the first question. Welcome, Dr. Carlisle.
Thank you. Thank you for having me here. Great to see you.
So, Dr. Carlisle, can you talk about contributions of HBCUs in producing physicians, pharmacists, nurses, clinical researchers, in creating a diverse healthcare workforce?
Well, those contributions are legion. It's certainly true that if you look at PhDs, you look at judges, the vast majority of such individuals are still coming from HBCUs at one point or another. And so for generations, quite literally, African-American professionals usually got their training from an HBCU. At one point, college, graduate school, professional school. So this is a thread that weaves itself throughout, I'd say, the entire community of African-American professionals who have made so many significant contributions to our community and American society as well. And it continues today, especially in the sciences in particular, for example, because you've got schools like our institution, Charles R. Drew University, like Xavier of Louisiana, so on and so forth. Florida A&M, I could just keep going down the list, Howard University, Morehouse, Meharry. Not only are we training individuals, but we're making very important contributions to advancing science in these areas as well. Federally funded research programs, fellowships, clinical training opportunities. The list just goes on and on. And so this process is central to moving the agenda on the health of the African American and other communities as well.
Well, can you share a little bit about Charles R. Drew University?
Sure, thank you very much. We were founded in 1966, so we're relatively young, especially compared to other HBCUs. So we were founded in a direct response to the violence that occurred in Los Angeles in 1965, the Watts Uprising, the Watts Revolt. At that time, there was little higher education opportunity in South Central Los Angeles, and little healthcare available as well. So the goal of the community was to create an institution that could provide both. And hence Charles R. Drew University of Medicine and Science was created, absolutely in response to a community need, which is why we call ourselves a community-founded institution.
That's wonderful. As a proud graduate of an HBCU, it's an honor for us to be able to work with Charles R. Drew and just to learn so much about the work that you all are doing in South Central and in Los Angeles region. And I know you're the only HBCU west of Texas, so that's pretty significant. So thank you for the work that you all are doing on the West Coast. And, it's just amazing how your institution actually has an impact not only in the African-American community, but also in the Latino and Asian community. Can you talk a little bit about that population and the work that you're doing in those communities as well?
Yes, absolutely. Los Angeles is a very, very diverse environment. That diversity exists in the area that you definitely spoke to. Our community where our school is located, when the school was founded, was 90% African-American. Today, it's about 70% Latino. But we still contain what I'd call basically the center of gravity of the African-American community in the Los Angeles area. All these areas, neighborhoods that people have heard of, perhaps Leimert Park, for example, Crenshaw. Those communities are heavily African-American and heavily Latino as well. And the Latino population and some elements of the Asian Pacific Islander population definitely share circumstances that would be called under-resourced.
Mhm.
And you see those circumstances manifesting themselves in a variety of ways: lack of health insurance, poor outcomes, poor educational opportunity. And when I think of some of the Asian Pacific Islander communities, such as the Cambodian community in Southern California, such as the Hmong community, they share many aspects of this as well. So if we're targeting being under-resourced in healthcare, we know that that is a broad brush that applies to a variety of populations. And our university serves all those populations, coming from the background of being an historically Black institution as well.
Well, thank you for that. And, Jennifer, I'd like to bring you into the conversation. Can you tell us a little bit about the Rare Disease Diversity Coalition and why it's important to develop, partnerships with institutions like Charles R. Drew?
Sure. Thank you so much for today, Dr. And also thank you, Shauna, for being here today. I appreciate both of you being a part of this discussion. The Rare Disease Diversity Coalition was just founded a couple of years ago out of the needs that we saw from various different types of survey. Within that survey, we recognized that the underserved population, as Dr. Carlisle mentioned, especially in the rare disease space, was really not getting the attention and the needs met. And so we felt like this coalition was really important. And we bring together rare disease experts, we bring together health and diversity advocates and industry leaders to really look for some evidence-based solutions to alleviate the disproportionate burden of rare diseases on those of the communities of color. And therefore, when you think of a university like Dr. Carlisle leads, it's really important for those folks to be at the table, because everywhere from the folks that are actually in school learning about rare diseases to the greater community that it services, like in the LA area, along with the alumni, the conversation keeps going and the education is there. And because rare diseases as a whole does not get the attention it really well deserves, you've got a multiple and spiral effect from the underserved population to the actual disease itself. So there's lots of opportunities for RDDC to work with great universities like Charles R. Drew because of the great work that they're doing within the communities and within the cities that they are in, especially for the underserved population. So I definitely see a long-term fit here.
Thank you, Jennifer. And Dr. Carlisle, can you share some of the things that you've seen over the years? Things or policies or initiatives that can be taken, brought here to Washington that can be implemented to help with the disparities issue in the African American and Latino and Asian communities?
Yes, that's a very good question. And I could take a long time to answer it and ruminate about the various possibilities. But one way I would tie it all together is to say that individuals with some of these rare conditions, rare diseases, and I'll certainly include, say, sickle cell anemia as an example in this category, the most common genetic disorder in the United States. It's difficult for them to often continue to maintain, for example, employment because of their conditions. If they can't maintain employment, it's difficult to maintain health insurance. And if you can't maintain health insurance, it's difficult to get the care that you need. And if you can't get the care you need, not only do you have a rare condition, but your outcome from that rare condition is probably going to suffer. And this is not just limited to sickle cell anemia. It could apply to a number of things: lupus, sarcoidosis, even more common conditions such as chronic renal failure, even diabetes and hypertension, not so rare at all, obviously, but the complications from them, strokes and things like that, may be a little bit more rare. And African Americans and other populations of color especially are disproportionately impacted by these things. So if I was to speak to a policy, perhaps in this realm, one thing that I might suggest in our circumstances is to think about things like special permanent insurance programs for individuals who have conditions like sickle cell or lupus or sarcoid, to keep them in the care loop so that they don't have to be dependent upon having health insurance or having a job to make sure they can obtain optimal care. This is still a big thing. I know that we've made a lot of progress in reducing uninsuredness in the United States because of the Affordable Care Act, but still these challenges do remain for populations with chronic diseases, rare diseases.
And thank you for sharing that. I know one of the things that we worked on together, Dr. Carlisle here in Washington, was supporting the Ways and Means Committee and helping to bring about more African-American doctors and figuring out how to get them to, one, to go to medical school, but then to come back to the communities in which they were raised in to serve, so that they can treat people of color with rare diseases and just and we saw this issue during COVID. So that's why it was exacerbated, and the Congress decided they really wanted to do something. So thank you for your leadership in supporting that area. And Jennifer, in your role and with RDDC, I know it's a new organization, but obviously it's something you're filling a gap that was needed. What are some of the things that you all are doing or would like to see done to address some of these needs in the RDDC in the rare disease space?
Yeah, there's a few things that, when you think of what RDDC does today, we've got 5 focus areas or 5 work groups that really are highlighted and trying to help with the health disparities and health inequities. One of them is being in the policy space, as you mentioned, with the legislation and working with governments and trying to do better for the underserved population, specifically around rare diseases. And so we've been really active in that space. And right now, as we're going from one year to the next and thinking about the mid-year elections and the new folks that are going to be in legislation there, we have some opportunities and changes in there. And so we're advocating for, obviously, for the work that needs to happen for the rare diseases for the underserved populations, everywhere from newborn screenings to extending some of the telehealth opportunities that came out of COVID, for example. So that's some of the things that our policy group is really focused on there. Some of the areas is around some of provider education. So working with some universities and others that have that opportunity to bring in rare diseases as some of their topics and various types of rare diseases to educate their students is part of the work that the provider group is doing. And then, of course, the patient and caregivers, how are they impacted? How are they getting their education? How are they advocating for themselves and really empowering them is part of the focus for that particular work group. And then we look at some of the things that happens in the clinical trials and some of the research components to it. And so there's opportunities there with universities, and there's opportunities there with the government too, to ensure that the clinical trials that have the population that does mirror the tapestry of the world that we are in, which is so multicultural now, and it's got so many of the minority folks now rising up to become more of the majority folks. So we really need to be mindful of what's happening in the population and the demographic changes there. So that gives you an idea, hopefully, a little bit of where our major focus areas are and how we can continue to really support this area and find opportunities to work with universities and HBCU schools to make a difference, and know that Black and brown doctors, for example, there's opportunities for them to go back to their communities once they do have their degrees and continue to build up on the trust. So trust and seeing a familiar face or somebody that's had that first real lived experience, I think also helps with the patient population, because we can't forget the history of this country when it comes to medical situations and how people of color were actually used as more or less tokenism. And so we want to make sure that as we move forward that doesn't happen again. And folks, even myself, when I see somebody that looks like me that's treating me, I feel like I have a better rapport and a better trust and understanding, and I can really listen to what somebody's telling me, and hopefully they can listen to what I'm telling them as an example. And that's very true for those that are living with the rare diseases.
That's great. Thanks so much, Jennifer. And Dr. Carlisle, I would love to hear your insights on the importance of clinical trials in communities of color. As a professional, I would love to hear your thoughts on that.
Yes, and I would definitely echo everything that Jennifer Waldrop just said, because we know that clinical trial participation is undersubscribed in communities of color. And a big reason for that is that the clinical trial leaders don't reflect those communities. As a result, those communities don't really connect with the agenda of direction or subject, sometimes even, of the clinical trials. And as a result, we develop strategies and techniques and research projects that aren't calibrated to the needs of communities of color. And we saw that, as you mentioned, Shauna, during the COVID pandemic, where it was very difficult to enroll communities of color in testing programs, vaccination programs, treatment programs, even just simple public health programs, until we realized that those efforts had to be led by members of those communities. And we experienced that at CDU, where our students were engaging the public directly and saying, this is important for you. And it makes a big difference when you see somebody talking to you who speaks the same language, looks like you, may even go to the same church that you go to. That's transformational. And this is really what we need to do in clinical trials to really achieve the level of engagement that is necessary to continue to develop success.
That's great. And Jennifer, would you like to share, any of the initiatives, any additional initiatives that the Rare Disease Coalition is working on, and why it's important for the organization to be engaged with stakeholders like Charles Drew and other medical schools that are within the HBCU community?
Sure, absolutely. So when I think a little bit about, from both the medical professional as well as the personal side of rare diseases, you can't help but think about your own family history. And there's been a lot of conversations, I think, in the news around genetic testing. And so there's been a number of celebrities, for example, that have gone through and done their own genetic testing, and they've been very public about what came out of those testings and how they're going to behave maybe a little bit differently and what they're going to do now. And when we think about some of the work that RDDC is doing, genetic testing is one of those areas. There's lots of opportunities for more folks to actually go and take these tests so they can understand perhaps their genetic makeup and how does that come through when it comes to possibly rare diseases. And so I think there's some of the things that we're all doing is really focused on advocating and working with others to bring forth the importance of genetic testing when it comes to rare diseases, especially. And then when I think about my own family history, my genetic makeup, and even just understanding of what my own history is. So talking to my family about the our family history when it comes to health is really important too, but not everyone's very comfortable with that. And as Dr. Collin mentioned, there's a lot of similarities in communities of color where a lot of times families don't talk about their own healthcare, their own background, who got sick when, and when did they get sick, and what did so-and-so die from. And that's very true in so many people that I've spoken to in the various communities of color, for example. And so there's a lot of similarities because some of the pain points when I talk to African Americans, as an example, really resonates in the Asian community. So we have a program called Know Your Family History. And in that Know Your Family History toolkit, it helps break down and tries to make it a lot more realistic, reasonable, and palatable to be able to talk with your own family members about your family history, and also talk to your provider a little bit about your family history. So we're starting kind of there from really understanding from the personal side of folks to be able to really understand themselves and their own family history in order for them to make informed decisions, and especially around the rare disease spaces. That's one, I think, really successful program that we're working on now. And I mentioned some of the policy work we're doing. And then, we continue to work with universities to try and educate their students around some of these rare diseases and bring it into the curriculum so that as they go in to become doctors and clinicians and others, that they're able to continue to remember when they're evaluating patients, perhaps to consider a rare disease in that evaluation, because there's lots of data that shows that there's delay in diagnosis when it comes to rare diseases, period. So 5 to 7 years, sometimes it takes that long to actually diagnose a rare disease. And then when it comes to minority populations, it takes even longer. So the fifth part of the work group that we do have is around delay in diagnosis as well. So we want to be able to shorten that time span.
Thank you, Jennifer. And Dr. Carlisle, we'll close out with a question to you. For those who will be listening to this webinar, is there anything you would like to share about HBCUs and the importance of our HBCU medical schools and the impact that they have, and why organizations like the Rare Disease Coalition and others should be supportive and really begin to consider engaging with our medical schools in the HBCU community?
Yes, when I think of the HBCU community in general, a word that comes to mind for me is power. These institutions, individually and collectively, harness a great deal of institutional and population power to do things. And working together, we harness that power even more effectively. I'm in fairly regular communication with the presidents of the other three historically Black medical schools, Howard, Meharry, and Morehouse. We work together on a number of things. We work together to respond to the COVID crisis. We work together to tackle breast cancer, any number of conditions. And the reason we work together so effectively is, despite the fact that we're in different geographic locations, we share a commonality of purpose, a commonality of motivation, but also a commonality of populations that we serve. And so, so that kind of cohesiveness that exists throughout the HBC community, it's not just the medical schools, is being used and can be used even further in the future to channel any number of projects focusing on underserved, underrepresented, under-resourced communities, especially communities of color. So again, working together, we've demonstrated that we possess an amount of power that is greater than our individual whole.
Well, I definitely thank you for your leadership and your mission and your purpose. I know I've definitely been in Washington for a long time now. I'm seeing the impact that you all are having. I'm hearing from so many different members and offices and within the Biden administration how they can do a better job with working with HBCUs. We're seeing legislation being introduced, like you all were helpful with on even getting more doctors to become hematologists and helping to figure out a way to pay for their education so they can go back to their communities and address sickle cell, particular for adult individuals who have sickle cell, because there's a big gap there. And so just thank you for all the work that you're doing. And Jennifer, I know Rare Disease Coalition is working extremely hard to make a difference and have a great impact on policy here in Washington, D.C. And so we just appreciate the work that the Rare Disease Coalition is doing, as well as the Black Women's Health Imperative. And we thank you all for your taking time out today for this wonderful discussion. And we look forward to continuing the partnership, because I know Charles R. Drew is a part of the Rare Disease Coalition. And so I think it's just an example of what individuals, organizations can do together to have an impact.
Thank you. It was a pleasure.